So, you know, it has been a long journey, but it has been a shared journey, and from the start, it's been instrumental that we have cross-sector representation. And again, from the very first meeting that Greg and I had, this is all about the patient. And unfortunately, that's a reality that I see as a clinician in a public eye clinic every week. Patients coming to my clinic, often for the first time they've seen anyone for their eyes, with end-stage eye disease, and this is happening in Australia. I had the fortune of working in the UK for a couple of years while I was doing a postdoctoral fellowship, and I worked in the public hospital eye clinic, and I did not see cases like this that I see on a weekly basis. So that was a really strong incentive for me to try and make a difference, because it's not good enough for us to see patients at this time when most of this is avoidable and preventable. Not easily so, but it is possible. So we know that diabetic retinopathy is very common. We've just recently conducted a national eye health survey where we went to 30 sites around Australia and sampled people over the age of 50. And we found that of those with self-reported diabetes, 1 in 3 had diabetic retinopathy to some extent. And it was sight-threatening in about 6% of non-Indigenous Australians. Unfortunately, the statistics are, as is the case for most diabetes complications, far worse in the Indigenous community. Rates of vision-threatening diabetic retinopathy are more than double. So if we think about the Australian population, we know that there are around about 70 to 80,000 Australians currently with one of the most common sight-threatening complications of the disease, which is macular edema, swelling in the area that's responsible for central vision, that interferes with daily function, driving, reading, recognising faces, and that is sight-threatening in 3 out of every 5 of those people. So you just need to cast your mind to the MCG. A pretty capacity crowd is the number of people we're talking about at a national level. It's a large number. And of course, we know that the risk of these complications increases with duration of disease, if there's been suboptimal control of risk factors, and we know that there are high-risk groups. We've already mentioned Indigenous Australians, communities that are culturally and linguistically diverse, and also high-risk periods of life, so people with pre-existing diabetes or women with pre-existing diabetes during pregnancy. And we can do better. But we know that there are challenges. There is, of course, as Greg alluded to, that massive challenge of scale of the problem. You know, there are millions of Australians, or at least 1.5 million Australians, who need to have regular eye checks, and that poses a system challenge. Around the world, the number is staggering, around 400 million people. And of course, it's not easy to have diabetes in modern day life. It's quite a hostile world with marketing and big food and so on. And of course, we're all tremendously busy in our daily lives. So even for someone without diabetes, it's hard just managing all of the daily life. But then if you have to think about your diabetes over 100 times a day and make decisions in relation to that, it's easy to imagine that it's easy for some of those risk factors to fall out of optimal ranges. So it's tough. And of course, our patients are being bombarded with different health messages, often conflicting about different organ systems, different risks, and it's very easy to be inundated by that. One of the main problems with diabetic retinopathy is it's often asymptomatic until it's at an advanced stage. And so it's very easy to worry about it later. If you're not bothered by your vision, it's very easy to just think about it later. And of course, engaging in regular screening involves behaviour change. Behaviour change for people with diabetes, but also our clinicians, our GPs who are seeing our patients. It's very easy for this just to be put into the too hard basket or left to the eye people. And with modern medicine, actually the eye has kind of fallen out of primary care. GPs no longer, in general, feel comfortable examining the eye for fear of missing other sight-threatening complications. And so we see this fragmentation, and that leads to poorer outcomes for people with diabetes. So we've got all the ingredients of success in Australia. Arguably, we have one of the world's best trained eye healthcare workforces. We have an excellent workforce of diabetes clinicians. We have subsidised eye examinations for all people with diabetes. We have this unique treasure that is the NDSS registry. We have unparalleled access globally to the very best medicines to treat established retinopathy. And we have a government that's very interested in investing in digital health. So it shouldn't be a problem. But as Greg also mentioned, only half of Australians with diagnosed diabetes are currently engaged in care. And that's largely because there's no system. There are gaps in this network. So what should be not a problem at all is a problem due to fragmentation, and people are falling between the gaps. So KeepSight seeks to address this. It's a reasonably simple concept. We will seek to engage people with diagnosed diabetes to attend an eye health practitioner. If they have an established relationship, they're invited to go and see their existing eye care provider. If they do not, there's an easy way via the website application to find an optometrist near them. They attend for an eye examination, and their eye practitioner registers that attendance, logs it, so that can be linked back to their NDSS record, so that it's a cross-check. We know then who's engaged in eye care, so that we can target resources to the people who are missing out. At the moment, we have no idea who is engaged and who is not. So that when life is hectic and they forget to turn up for their eye exams, there's someone else just saying, have a think about getting an eye check. Portal, the keepsight.org.au, where patients, or people with diabetes rather, can sign themselves up, or clinicians can sign people with diabetes up to participate in the scheme. There's also a communication portal called Oculo, which is a leading communication portal between optometrists and ophthalmologists, and there's a streamlined workflow there, and Alex is going to talk to us about the importance of that for the success of the program. So we've been live with KeepSight since early this year in April, and we have been having a fairly graded or gradual introduction of the program. We've done very targeted marketing, direct consumer messaging and mass media campaigns in select areas, and we're testing the impact of those strategies. So we've had 3 focus regions, Southeast Queensland, Southeast Melbourne and Western Sydney, and we're testing different strategies to communicate to people with diabetes in each of those areas, and we've got some very useful insights on what seems to be working best. The stages ahead are really around increasing those communications, mobilising larger numbers of people with diabetes, and that's going to start soon. Once the program's rolling, we want to be some more sophisticated and targeted in our messaging, because very clearly the population with diabetes is a diverse representation of the Australian population, and so all ages, all different motivators and drivers, and so we now are seeking to really tailor that engagement communication to develop messages that are relevant to different sectors of the population. Of course, the funders of the program are expecting measurable outcomes, and that's the government, but also Specsavers, Bayer, Mylan, Novartis. All of our funders are seeking to see evidence of traction. And in the short term, that's going to be things like registrations, because that's easy to measure, but then attendances, recall, successive recall. All of these things are going to shape improvement in eye health. We saw in the UK, where it was a very systematic rollout, that it takes about 10 years for this to really impact blindness rates. Unfortunately, we don't have a blindness registry in Australia, so that's another thing that we're going to be advocating for, but we need to measure the impact of our program. So here's just a bit of a montage of some of the early marketing material that's gone out. We've had highway billboards. We even have had signs at the local urinal. I'm yet to see one of those. We've had electronic messaging in GP practices, conventional media, social media, and the like.